Hi, welcome to Neurocare Academy. My name is Dr. Trevor Brown, and today we have a very special guest with us, Dr. Linda Carpenter, who's a professor at Brown Department of Psychiatry and Human Behaviour, and also director at Butler Hospital TMS Clinic and Neuromodulation Research Facility. Linda's going to be speaking to us primarily about maintenance TMS therapy, but we're going to get to know her a little bit first. So welcome, Linda.
Thank you for having me, Trevor.
Excellent. Look, very excited to hear what you've got to tell us about some of your latest research. But initially, look, Linda, I think it'd be really nice for our viewers to know a little bit about your background and how you've come to get into TMS research and combine that with your clinical application. So to begin with, where did you study and where did you grow up in the United States? And tell us a little bit about all that.
Yeah, sure. So I was born in a little town called Battle Creek, Michigan, here in the United States. That's in the Midwest section of the country. And Michigan is a state that's shaped like a mitten. So people from Michigan like to point, this is where they're talking about. And Battle Creek, where I was born, is known internationally as the cereal capital of the world because Kellogg Cereal Company world headquarters were there. And so you could often smell Kellogg cornflakes in the air in the areas where I was growing up, competing if the wind blew the other way with the dog food company, which also had corn smell in the air. But I grew up in Michigan and I did my undergraduate education at the University of Michigan, which is in Ann Arbor, and studied psychology there. I went from psychology thinking I would go do a PhD in clinical psychology and become a therapist. Applied to some programs, but then I ended up deciding to do something a little bit different instead. Went to Pittsburgh, Pennsylvania, where I joined a group of researchers there and studied depression for 3 years while I was getting some other requisite classes for medical school. So after 3 years in Pittsburgh, Pennsylvania, studying depression, and at that point, tricyclic antidepressant imipramine for depression, I went on to medical school at Penn. The University of Pennsylvania is in Philadelphia. And after 4 years of medical school, I was interested again in psychiatry and still in depression. So I went from there to Yale University in Connecticut, where I studied psychiatry residency for 4 years, specialized there, and had another training in research, a fellowship after my residency. After finishing that, I was ready to take on a faculty position and was recruited here to Brown University, the medical school here, which is in Providence, Rhode Island, just a little further up the East Coast in the United States.
Fantastic. What a journey. So lots of education there. And then you started practicing, and really with your background, both in research and your medical degree, you tried to then balance between your clinical expertise and also your research expertise. And that added to what you were able to offer us and really, I guess, groomed you to get into the sorts of things that we know you for now, the safety and ethical guidelines, the clinical application of TMS. Can you tell us a little bit about that balance between the clinical and research side?
Yeah, I've always been somebody who is taking care of patients here at Butler Hospital, inpatients, outpatients, and that has really informed and inspired my research questions. I've always been interested in mood and anxiety disorders and the patients when I'm not able to get them better, what causes their illness and how to treat it when the standard usual medications and psychotherapy don't work. And those experiences have really inspired the types of research proposals and questions I've addressed, brought me through a journey of studying a biological risk for depression and stress biology to the point of discovering and working on treatments that might benefit people who were still depressed after they had tried the usual psychotherapy and medications such as vagus nerve stimulation implants and deep brain stimulation for depression, and then ultimately transcranial magnetic stimulation. But I've been really lucky that I take care of patients who have those disorders and inspire the research. And then also many of the people that I take care of are participants in clinical trials with new devices or in studies looking for biomarkers of one type or another. So there's a very close mixture and integration of my clinical work and my research work.
Yeah, that's awesome. Linda, look, what we're trying to do at Neurocare is trying to bring the research to the clinician as quickly as possible. And I think, you bridge that gap very well already in all the clinical research that you're doing. So look, anything else you'd like to tell us about your background before we go into your current research, or would you like to jump in and share your slides and tell us about the maintenance therapy?
Yeah, I can jump right in and tell you about maintenance therapy. I've been involved with transcranial magnetic stimulation since the time that the first FDA approval happened here, and that was in October of 2008. And then, the company Neuronetics was launching the first device all around the United States, and people were very interested in how does it work in non-research settings. This is something very different for psychiatrists to be doing. And so I was involved early on in some of the very practical questions, not only how effective was it in real life clinical settings and non-research settings, but many of the questions that came along with using TMS therapy, how to make it work its best, how to pick the right candidates. There's so many different parameters. And among those questions is, okay, those large-scale clinical trials have demonstrated for us how to get people better, but then the follow-up question would be how to keep them better after you finish a successful acute course of TMS therapy. So that's really one of the patient care dilemmas that have inspired some of the research that I've been involved in.
Yeah, fantastic. And to have you talk about the history of TMS and all those sorts of questions is really inspiring for us, because a lot of us just, the younger generation, who, especially those students who are going to be watching this, will be thinking to themselves, well, how did this all come about? So, I think it's really interesting to hear what were the first questions, what led us to this point. So, anything that you want to add to that, to lead into what you're doing today, feel free to sort of elucidate that for us. All right, thanks very much, Linda, about that for that background. You're going to be talking to us today about primarily the maintenance of TMS therapy. So you've got some really groundbreaking or recent research that you've done. So I look forward to hearing that from you. Thanks very much. Go for it.
Sure, thank you. All right. Hopefully you can see my cursor there. I start off with financial disclosures. It's important for people to know that when you have expertise in this area, you often are consulting for companies that are developing new treatments and devices, and you should pay attention to that and make sure that if at any point it feels like I have bias in the way I'm presenting these things, that you call me right out on it. I've been a consultant or a scientific advisor to a number of companies that make pharmaceutical products and devices to stimulate the brain. So back when I was young and working in Pittsburgh, I worked with the chairman of the department, this gentleman, Dr. David Kupfer, and together this very important paper was published in the American Journal of Psychiatry, which defined this sort of classic model for major depression. And the idea was you start out normal, and then your symptoms come, and you start getting treatment. When you have symptoms, it brings your symptoms down, and then you start to get better. And when you're 50% better, we call that a response. And then you get all the way better, and that's called a remission. And you sail off into the sunset, perfectly happy in your full remission. Although you could have a relapse if symptoms came on and the remission didn't hold. And at some point with a long remission, you get to the point of recovery. After you've recovered, maybe you have a new episode of depression, and we call that a recurrence. And that was sort of the first time in 1991 that we tried to put structure to depression, these episodes and these recurrences and incomplete recoveries. But the truth is that there are a significant number of patients who have what we call treatment-resistant depression, and they don't have that classic pattern of remission and recovery. They don't get better with medication after medication after medication and psychotherapy. There was this very large US government sponsored study back in early 2000, and it was called STAR-D, and that stands for Sequence Treatment Alternatives to Relieve Depression. And the idea here was clinics around the country engaged in this research and recruited in people with depression. And they gave them one good prospective trial of an antidepressant. They called that level 1. Those were patients who are not resistant, right? And if they didn't get better with that, they took those patients and then they exposed them to the next treatment and gave them a good prospective, adequate course, adequate duration for the next antidepressant with scales and assessments throughout. And they called that level 2. They had one prior treatment failure and so on. If they didn't have remission, then they put them right into level 3. And if they still didn't have remission, they put into level 4. So level 4 would be people with the greatest resistance. And the purple line here, level 1, would be people who are non-resistant. And what this shows us is that after they get their treatment, what you're looking at in these curves is the relapse rates after they've had some effective treatment once they get better, right? So you start here, you get better, and over time, you're seeing that here, the people with the highest level of treatment resistance, they fall off that curve very quickly because they're prone to relapse very quickly. And less resistant patients go a little further, but even then, by a year later, you've got about half of them have had another episode of depression. And we just really learned from this that depression is rarely a one-time event in one's life. It's often recurrent. And for those who are resistant, whose illness and symptoms are resistant to multiple medications, their durability of effect is even less so. So that really brings up this challenging question of how do we get people better, one, but then how do we keep them better? And TMS is stunning for helping to get patients with TRD, treatment-resistant depression, to the finish line, but then how do we keep them better for the long run? Well, these data show us that after successful TMS, so you take patients who have not remitted with all these other treatments, you get them better with transcranial magnetic stimulation. This is 204 people. This is all retrospective naturalistic data. And they all had a remission, and then they followed them for 6 months after they finished their last TMS, right? And what you can see is that by 6 months out, more than 3/4 had relapsed and were having symptoms again. By only 3 months after, 40% of them had relapsed. And the investigators in this study analyzed their data to try to understand what are the factors that predicts whose remission is going to be more durable, what will help it to last longer once we get people better at TMS. And they found that people who were younger, their younger, healthier brains had a better durability of effect. And they also found that people who had been treated more completely, people who had more sessions during their acute course, wasn't like, oh, they had 10 sessions, hit remission, so we'll stop there. If they had treated longer, up to 30 sessions, they were more likely to hold on to their benefits longer. So I've really scoured the data as I was thinking about durability of effect and maintenance therapy, and tried to learn what I can glean from the existing literature. During the neuronetics prospective clinical trials that they conducted to get FDA approval, they had various types of built-in prospective extension trials, and they had a maintenance trial. And one of the things that we can glean from those is how likely we are to get more people better if we keep going, and then how quickly they are to fall off of their remission curve. We know that naturalistic long-term outcomes from 257 patients around the country. And again, this is after the launch of the device, where we collected data from these different treatment settings. What we showed from this is that by and large, about 2/3 of people who would meet criteria for what we call response, they got 50% better, right? They remained responders throughout the whole year of follow-up. So that's pretty good. That's better than we thought. 2/3 of them staying in the response category over a month. And we followed these people up every 3 months. This is treatment that was not paid for by any industry sponsor. It was just after launch into the market, and psychiatrists around the country in naturalistic real life practice settings. So we saw that was the case. You could keep about 2/3 of people better, but in order to do that, about 1/3 of them were getting some additional treatments. And at that point, everyone was just kind of making it up in terms of how often to do additional treatments. Would they do them prophylactically? Would they wait till somebody got better? We didn't have insurance policies covering TMS, and so it was a little bit of a chaotic, sort of everybody do your own thing in terms of how people were designing their approach to keeping patients better after TMS. And at that point in this country, the criteria for when you should retreat somebody or whether they even had access to get TMS again, and the schedule that we used were highly variable. We didn't have standardized insurance. So what we found that was that we could keep people better, but some retreatment had to happen after that acute course. And what was also striking from this study was that we looked at all sorts of pretreatment variables to try to predict, who is going to have a better, more durable outcome from their TMS compared to others. And none of them turned out to be statistically significant predictors. You'd say, when I give these talks, psychiatrists always say, I know which ones of my patients are going to relapse and they're going to have a recurrence. I can predict it. And I tell them, no, you can't. Actually, nothing has ever been able to predict reliably which patients are going to hold on to their benefits and which are going to relapse. So that's one of the background things that's inspired me to try to crack this nut and figure out how to do it the best way possible. So I wanted to back up a minute and talk about, well, how do I get the best durable response by giving the best, most complete treatment when I'm giving the acute series, right? So this is the point where you're giving TMS maybe once a day, 5 days a week for 4 to 6 weeks. And some people call this the acute phase, some people call it induction or the initial series, but this is typically 20 to 30 sessions. And again, we have to ask ourselves, if we can get our patients better, and we do such a beautiful job with TMS for the first time, getting these patients better who had not been better with other treatments, how can we use TMS after that standard acute course to keep them better? And I think the question requires that you ask not only like, what schedule would you use, but which patients would you use? What are the goals? What is feasible? What's cost effective? How do you measure the outcomes? And can you standardize a regimen and then prospectively study it and convince policymakers that they should pay for everybody to get it that way? So I want to pause for a minute and just define some of the terms that I use when I'm in this space. So here's a patient, and this is, let's say this is a score that they have on a standardized depression scale, right? And this is baseline before you start your first TMS, then you give your course of whatever, 30 treatments, and there you are at the end. And if they've haven't dropped their score 50%, we call that a non-responder, less than 50% improved, right? So this guy's gone from, 50 something, not even to 25. So we call that a non-responder. So the goal after you finish those treatments might be, I want to do more TMS to see if I can get this person eventually to be a responder. So I'd call that continuation treatment, right? So if I've gone through a whole course of 30 sessions and the person has not yet met response, I'm not going to call that maintenance because there's nothing to maintain. They're not there yet. I'm going to say what I do after this point, I'm going to call continuation. In this example here, the person has got 50% better. They've dropped from 50 down to 25, and here they are at the end of their course. And I might want to do one of two things. I might want to do continuation. I want to give them more TMS so that the goal that I get them further improved. Maybe I want to get them all the way to remission. That would be that arrow here. Or I might say, wow, that's fantastic. You got 50% better. I want to give you more TMS, and I want that TMS to maintain the benefits. I don't think we're going to get any better, but I think we really want to maintain this. And then another reason you might continue after an acute course is because you have a remitter, and that person's done spectacularly. Their score plummeted from the baseline to the endpoint, and now we really want to maintain that. We want to prophylax against the symptoms coming back. There really aren't any symptoms left because they're in remission. So those are different terms that I use. And then when I think about maintenance, I think about the scheduling, right? So there's different ways to do it. You can do extra treatments at fixed regular intervals. So you can say, okay, I finished my course at 30. Those were 5 days a week. And now I'm going to continue at a fixed regular schedule of 5 a week. And I'm just going to keep going 5 a week. Or maybe you can do like they did in the Brainsway trial and say, now I'm going to drop it down to 2 a week, and I'm going to do 2 treatments a week for the next 12 weeks. Or maybe you're going to drop it down to once a month, right? So I finished my acute course, I'm going to go once a month. Some people do this in a tapering frequency kind of schedule so that they go, okay, I'm going to go weekly for a while, and then I'm going to go one every 2 weeks, then I'm going to drop it to one a month. And that's very popular. That's what the Neuronetics study did. They did 3 sessions during the first week of taper, and then 2 the next week, and then 1 session, and then stop. Another model that people do when they're giving some sort of treatment after they finish acute series is called rescue treatment. Some people call this reintroduction. And the concept here is that your decision to schedule treatments is triggered by some sort of symptom reemergence or symptom worsening. So in order to implement that schedule, you would predetermine some sort of threshold and say, when this happens, I'm going to reintroduce TMS. And if your depression symptoms remain below that level, then I will not give any more TMS, right? So there are different ways you can do that. You can start with an acute phase, 5 days a week, and then titrate the frequency. You can go, okay, your depression has come back, so I'm gonna taper up. So I'll start with 1 a week, and if you don't get better, I'm gonna jump it to 2 a week, and then I'm gonna jump it to 5 a week, so you can escalate the frequency just like you did tapering down. Or yet another strategy that I've been very intrigued by lately, and I'll tell you about at the end, is called a cluster maintenance. And that is when your depression comes back, you hit some threshold, and instead of just jumping into 5 days a week, I'm going to give you a little cluster, a little burst of them. Maybe I'm going to give you 5 sessions over 3 days, or there's a couple different strategies for clusters, but they be grouped together in time, and then you wait and go on till the next event happens and give a cluster. So Neuronetics showed us in their prospective clinical trial that if you didn't have response at the end of 4 weeks, that's 20 sessions, and you kept on going, this is an additional 2 weeks, an additional 4 weeks, an additional 6 weeks. So at this point, you've got people who are having 10 weeks, and this is a crossover. So I don't want you to pay attention to these gray bars. Those people who had, they had blinded sham treatment during the first phase of the trial. What we're looking at, what I'm interested in here, is the people who already had active treatment for the first 4 weeks. And so the black bars are people who are extending their course with 5 more sessions each week. It's like they went through a whole course and then they're doing a whole nother course. And what we learned here is that you can get about 1/4 to 1/3 of people converted to responders that were not responders. That's why I have the little Jesus over there, because those were the conversion rates. And I was very impressed by that. And you can see here, using a different scale, you convert about 1/3. And you even convert with continued 5 days a week, you convert some of them to remission. And you'll remember in that first slide that one of the things that a naturalistic data set found was that if you more completely treat and don't stop early, that you have better durable response. So continuing after some set amount like 30, you can get more patients into the remission and response categories. And another device trial, the Brainsway Deep TMS study, did a similar thing. They gave 20 sessions, once a day for 4 weeks, and then they got to those the end of that acute phase, and then they called it maintenance. I would call it continuation in some cases. When their schedule was 2 sessions per week for an additional 12 weeks. And the curve that you see here is people who were non-responders converting to responders over time. And in this particular study, they didn't know whether when they entered this 2 days a week schedule, whether they were sticking with blinded active or blinded sham treatment. So a slightly different twist on the design, but the message is similarly positive. 73% of people who were not responders after they finished their first 4 weeks of 5 days a week treatment became responders by continuing with additional treatments over those additional 4 months. So encouraging news. There was a study that was funded by the United States government called OPT-TMS, and OPT stands for optimize. And in this study, they use a novel way to do the sham so that it would help the participants stay blind to not guess whether they were getting active or sham treatment. And in this particular trial, if they didn't get better with 10 hertz stimulation on the left dorsolateral prefrontal cortex, they had the option to switch over to the right side and use 1 hertz, a slow pulsing over the right dorsolateral prefrontal cortex. And the protocol was slightly different, but they were both at 120% of the motor threshold. And what they found is that if you continued, again, either with more stimulation sessions on the left, they were doing them 5 days a week, or if you switched over to 1 hertz on the right, either one of those converted more people into remission. 44% of people who continued on after the first 3 weeks achieved remission with these additional 5 days a week. So what I'm talking about sounds like it's not maintenance because these people are still going 5 days a week. It sounds like an extension of the acute phase. And really it is. It's just continuing to go past what you thought was going to be your endpoint. And in this particular case, some of them switched over to the other side. And in all these cases, more and more patients are becoming responders. Again, another study with an H-coil design, and these are patients who had acute treatment daily for 4 weeks. That's their first 20 sessions. And then this group used a taper, right? So then they tapered down to twice per week for 8 weeks, and then down once per week for 10 weeks. And they continued to get more people better over time over this tapering schedule. So it's not like they're just holding on to the benefits. They were actually getting more people better. And they converted 14% of them to responders during the first continuation phase there. So I think I've beat home the point that continued treatment will get more patients better. What about the people that are better now and keep preventing them from falling off and becoming depressed again? So this is a relapse study that Neuronetics conducted after they had finished treating people through the acute course, and that had 2 things built into it. One of them was that everybody got monitored, and when they had a symptom worsening, when they had symptom worsening at a certain threshold, they were allowed to get TMS reintroduced, retreated to them. And also, as they entered this phase, they came out of the blinded clinical trial, they transitioned on to a medication. So here we have patients who are medication-free, they've gotten better, they transition on to a medication, and they go into a long-term follow-up, they're monitored. And if they get a certain level of worsening, and they define that worsening as 2 consecutive weeks or a clinical global impression scale had an increase in severity by a notch. If they had that for 2 weeks, then they started treating. What schedule did they use? Well, they started we'll give you 2 sessions a week for the first 2 weeks. And if you still aren't better, we'll escalate it. We'll go up to 5 sessions a week and offer that for 4 more weeks. And if at any point along the way, your clinical global impression scale goes back to where it was before at baseline, we'll stop. And so that's kind of escalated up if you're not getting better. And then when you are better, we'll just dial it back and go back into monitoring. And what they found is that over this course of 6 months, there were 38% of the patients, even though they had transitioned onto an antidepressant medication, even though they had originally done well with TMS, 38%, more than a third, started to have that threshold symptom worsening. They started to have their symptoms come back. And then those people, of course, according to this algorithm, got rescue TMS. And 84% of these people that started to slip were rescued. They effectively got better again. And so I tell my patients, there's a high chance that you will have your symptoms start to come back, but there's also an extremely high likelihood that if we give you TMS again, that you'll get better again. So that's the good news. The bad news is the benefits you get from TMS won't last forever. The good news is we can restore them if we bring TMS back into the picture when your symptoms come back. And when you look at over this cohort of 99 patients, there were the mean number of sessions across the whole group of additional TMS treatment sessions was only 14. So it wasn't like loads and loads of additional treatments were needed. Despite all that, there were 13% of patients that even though they tried to rescue them, they had full depressive episode relapse and they didn't improve despite additional TMS treatment. But being able to rescue 84%, I think is quite impressive. So then Paul Fitzgerald and his team in 2013 introduced the first study where they did weekend cluster maintenance. And I thought that this was a really interesting design. It turned out that they had a setup with their clinic in a hospital where the device wasn't available very much because they were treating patients all during the week, the regular, and they wanted to do some follow-up and maintenance, but there wasn't much access. So what they did was they invited 35 patients who had gotten better. In fact, they had got better twice before with TMS, and each time they had relapsed again. And they said, okay, when you need it now, we're going to give you cluster treatments. And so you come in on a weekend, we'll give you 1 on Friday, 2 on Saturday, 2 on Sunday, and then you go back home. And we're going to do this once a month and see how well it works out. And the TMS protocol was the same at each cluster. They gave whatever had worked during the initial course, which was usually 10 hertz on the left, but it could have been 1 hertz on the right, or some sort of bilateral protocol. And I thought this was a really compelling, even if it was designed out of convenience, the idea that you would put a little bolus together and they evaluated them once a month. And they demonstrated that more patients were able to stay well with these weekend cluster maintenance. They had a rate of 71% relapse over 48 months, and that's a high relapse rate. That's what happens with TMS, about nearly half of them within the first year. But they also found that they were able to keep more patients better longer, for a longer period of time after their initial TMS course, by offering these rescue and cluster maintenance treatments. And they were set out to do it needed or not, sort of as a prophylaxis, but people were falling off their remission very quickly. Part of the reason that was happening is because their course of treatment was only 20 sessions long, and that probably isn't the most durable effect they could get, but that was the standard they were using. So with all this as backdrop, we decided to do a prospective clinical trial at 5 sites and ask the question, can we introduce a prospective maintenance schedule that will prevent people from relapsing and prolong the durability of their benefits? And this was a study that Neuronetics sponsored. And we decided to use medication-free patients, so we would be clear that what we were doing was affected by the TMS therapy and not by some other concurrent treatments. And the schedule that was proposed was borrowed from ECT, electroconvulsive therapy, and the decision was made that we're going to give people 1 treatment a month, needed or not, after they get better from TMS. And so this was 6 sites, and there were 67 patients. These were ones that went through an acute course and they did well. They had a response or remission, and 49 of them were randomized. So you got randomized to one of 2 groups, either 1 a month, needed or not, or we're just going to observe you and have you come in for an assessment once a month. In both groups, if you slipped to a certain level of symptom return, threshold relapse, you were allowed to get rescue treatment. Both groups could do that. And we thought, we'll just keep everybody off their antidepressants and do this over a year. Well, again, we randomized 49 people into what we called scheduled TMS. That's a once a month or observation only. And you can see some description of them here. These were patients who were willing to remain medication free over a year. And at the time that we randomized them into this maintenance study, there were a very high representation of people that were in full remission, 83% of the scheduled group and 89% of the group that was just getting observed. So what we found was that there needed to be some defined algorithms, some set rules for what we're going to call a trigger and reintroduce TMS. And this would be for both groups, whether they're getting the 1 a month maintenance or just observation. And what we decided is that if they had a Hamilton 17, that's a depression rating scale score, which was 25% worse from when it had been at baseline before they got their acute course, and if the score was over 16, then that was going to be the trigger. We would call that trigger for worsening, and we would schedule reintroduction. Instead of titrating up and escalating the frequency, we said when they hit that level, we're just jump right in there with 5 days a week. And we'll assess them after each 5 sessions and see if they get better. And when they get better and return to their the value that they had before they clinically deteriorated, then we would stop. And if they went all the way through, if they relapsed and we gave them 6 weeks and 3 more treatments and they weren't better, then they exit the study. So they were allowed to get multiple courses of TMS reintroduction if they needed it. So that was the schedule. And now you have a group getting 1 a month, need it or not, a group getting observed and getting nothing. And both of them, when they hit symptom threshold for trigger, they would start in with 5 sessions a week until they got better again. What did we learn? Well, what did we find? We found that 1 a month was not enough to statistically separate these groups. So it did not protect the group that was getting 1 a month, was not superior in how long their remission lasted or how durable their response was over time. It looks like a little bit like you can see these 2 curves are a little bit different from each other, but it didn't quite hit it. It was not good enough. And I speculate that that's because some patients don't even need 1 a month and others need more than 1 a month, right? And in fact, if you look at the groups here, the time to relapse, the scheduled group who was getting 1 a month, their average was about 91 days, and the group that was just being observed, 77 days. That was not statistically significant between them. And the numbers that were sustained over this whole year were also similar. So what do we see here? About 39–40% of people in one of the groups didn't need any more reintroduction. They stayed well. And in the other group, 35%. So you'd be safe to say that in both groups, over 1/3 of people who got better with TMS, remained off medicines, could go for a whole year and didn't have their symptoms come back. So what does that mean? Some people don't need maintenance TMS. Not everyone needs maintenance TMS, but other people really do. In fact, if you look down here, you can see the number of reintroductions. Some people, there were people who needed 5 additional reintroduction courses of TMS over a year. Luckily, that wasn't many people. That was only 1 person. But you can see that there was a person that needed 3. There were 10 people who needed 2 courses of reintroduction. And there were 17 people who needed 1 course of reintroduction over the year. So it's common to have triggered, 2/3 of these people had some slipping, their symptoms started to come back. And the average number of treatments that they needed, not so much, 15, 20, but the range was great, from none at all to a whole lot. And we really couldn't tell the difference between them with just by giving 1 a month, needed or not. And this was really one of the beginnings of my really feeling that we need some way to personalize and customize our maintenance schedule, right? Because some patients really won't need maintenance. And you wonder, Trevor, you have to wonder, if you're giving people a treatment and they don't need it, might they develop some sort of tolerance, and then when they do need it in the future, it might not work well for them. We don't know. That hasn't been tested with this particular treatment, but this concept of tachyphylaxis does exist across different areas of medicine. So it's something to think about. So 1 a month wasn't better than just watching and waiting. And we also learned that when you keep people medication free, the risk for symptom relapse is high. It's about 2/3. And I tell my patients, when I interpret this, I say, these relapse rates were much higher in this study where we kept people medication free after TMS. And I recommend for my patients, if they're not already on an antidepressant medication during TMS, that we transition onto one to help maintain the benefits. There aren't head-to-head trials, but there's certainly some suggestion here with these high relapse rates and medication-free patients that even being on some medication might help the durability a little bit. So we also learned that rescue treatment was highly effective. If people get to a threshold worsening and you give it to them, the majority of them you're going to be able to rescue. And data since then have really supported and replicated that finding that when patients do clinically deteriorate and you reintroduce the treatment, you can get them better. So we've seen that over and over and over. So here's another model, an early relapse TMS protocol that Pridmore and colleagues published in 2018. And they used a fixed schedule of 1 cluster per month. And their cluster was 5 sessions over 3 to 5 days. So they could have done 1 a day, or they could pile up 2 a day. And there's a lot that your community are hearing about: multiple treatments per day, accelerated treatments. I'm not going to figure that into the talk today, except for to say that in a couple of these clustered designs, they've put 2 in a day. And there's a lot of questions for us, like how close should they be together and all that sort of thing. But here they were interested in looking at how many clusters people needed and how many would relapse despite having these cluster maintenance sessions. And they gave 168 clusters across patients. And one thing that was really useful takeaway point for me from this is being able to measure the effect of a cluster maintenance intervention. One of the problems with maintenance in general is, how do you measure when it's effective, right? So if you give people 5 days of treatments and then you give an assessment and your scale says, how have things been in the last week? Rate your sleep, rate your appetite. And you're like, oh, the last week, the last 7 days. And things have been changing because you've had 5 treatments in the last days. So it's very hard to, you really kind of wait a few days and give them a weekend to see how they're doing without their symptoms. So it's kind of hard to get valid assessments with our standard tools when you're trying to do it in real time, giving maintenance TMS sessions. But they used this Hamilton 6, which is a modified version of the Hamilton, and they were able to measure pre and post. This is pre-cluster, post-cluster, pre-cluster, post-cluster. And they were really able to illustrate how those clusters brought those symptoms down in patients by using a scale that doesn't ask you to have to rely on a week's worth of symptoms in such an elaborate way. So here's some facts and here's some gaps. After an acute course, and we're calling an acute course 5 days a week for whatever 20 to 30 sessions, some non-responders will convert if you just keep going at the same schedule 5 days a week. Most responders and remitters are going to lose their benefits and they're going to relapse eventually. Even if you do give them more, they're going to. That's just part of treatment-resistant depression. In fact, it's part of depression in general. It is really something that we have to think of more like diabetes when we talk to our patients. This is usually not a 1 episode and done for the rest of your life. God bless you if it is, that's great. But we have to prepare people for the idea that can be chronic and relapsing and remitting and recurring. However, some of those patients, you can't tell them all it's all gonna come back, because some of them will go a long time, a year or longer. I had one patient in my clinic that I treated when I first opened in 2009, and she came back just recently in 2020 after 11 years. She had done great, and she had a relapse, and we treated her again, and she got better. So I haven't been at this more than 12 years, 11 years to be able to see other people, their stories, how long they've done, but doing well for a decade is a great outcome. So about 1/3 to 2/3 are going to start to relapse and start to have some symptoms come back within the first year. Rescue rates are high if you jump in when they're symptomatic. Now, I don't know what happens if you give it to them prophylactically when they don't need it. Again, there's that question of whether you could develop tachyphylaxis. But it does seem that in order for these rescue treatments to work, you have to have regular clinical monitoring. And I don't know what it's like in TMS clinics around the world, but my clinic is an adjunct clinic. So there's patients who are treated by doctors in the community and therapists in the community, and they come to us, they get their TMS, and they go back to their prescribers and their clinicians in the community, and I don't necessarily see them. So in order to rescue them with TMS, I would need to know when their symptoms are starting to come back, right? So that monitoring is so important, and not everybody has incorporated regular rating scales into their monitoring. We can't predict based on clinical characteristics. We've tried, we've bent the statistics 101 ways. We cannot statistically predict based on how many episodes you've had, how many meds you've had, what color your hair is. We cannot predict who will have relapse soon and who will last longer. All we can say is that more treatment resistance, you're likely to relapse, and with more failed trials, but that has not even borne out consistently in TMS studies. Clusters seem time efficient, but we really don't know the optimal number, how much time to put between them. And there's feasibility questions. If you tell Mrs. Jones, okay, you have a relapse, come in and I'll give you 3 treatments this day, and you have 1 device in your clinic, well, she's taking up 3 hours of it. Now, what happens to all the other patients who were supposed to be treated during those slots? So there are some logistics with people coming in and clustering and bunching up a lot of treatments in one day. There are individual variability and patterns of a disease progression. This is one thing that I've noticed in my very recent work, which I'll tell you about in a minute, which is that some patients start to gradually worsen, and they gradually get worse, and then they're at this threshold level and they're depressed and you treat them again. Other people, they have a couple, 2 bad days, and then they're tanking really fast. They're clinically deteriorating, and if I don't do something soon, they're going to end up in the hospital or in trouble. So there's differences between patients that are important to take into consideration when we think about maintenance. And also, I have to remind us all, we have to remind ourselves that transient worsening, some depressive symptoms are totally normal in certain contexts, right? So if you're monitoring your mood every day, you're going to have days where it sucks, but that doesn't mean you have to come in and get more TMS, right? Because you might be fine the next day, or maybe your cat dies, your pet dies, and you're feeling poorly for a couple of days. We want to not jump in too soon and treat something that's not really a relapse. So that and assessing the outcomes are real challenges in developing a proper and a real solid foundation for maintenance. So we have naturalistic data here from my clinic on retreatment courses. And this is just more data showing that when patients come back right now in America, insurance companies pay for you to get TMS when you're really severely depressed, moderately severely depressed. Then, until fairly recently, you would go away and do your thing, take your maintenance medications, take your psychotherapy, whatever you're going to do, and they wouldn't pay for you to get any more TMS until you had crashed and burned, you're back to a severe level of symptoms again. And that's because the insurance companies and the policymakers say there is no prospective validated schedule for how to give maintenance therapy. You might just be giving it to everybody. They don't need it. We don't know if that's good for people. We need to show what's better than just waiting until they're sick again. Besides, patients don't want to wait till they're sick again. We don't want to wait till they're severely sick again, but we want to do it right. So the research that I'm involved in now is a Neuronetics sponsored study, which uses an app, and it's a customized app with an algorithm that we're testing. And it's called Ecological Momentary Assessment. When you assess people in the field, rather than saying, oh, when you come to my office visit, I'll give you a scale and you can fill it out with paper and pencil. The idea is it captures you in your daily life. A notification jumps up on your smartphone and says, fill out this 9-item scale with your depression. And then it also keeps track of what your ideal score is. So when you finish TMS therapy, I look at the scores where you started, they're very high. I look at the scores when you finished. Maybe patient X finished with a score of 0, beautiful remission, no symptoms at all. And for another person, they were at a 10, and that was really good for them. So I have to figure out what the target is for each of these patients. And this algorithm we're developing keeps track of each person's individual target. And then each week they fill out these scales. And it's monitoring them over time to see how much variability they have. And then it says, okay, at some point you've reached a trigger. You're eligible for a cluster of maintenance sessions. Would you like to have them? And you can say, no, I don't think I'm really that bad. I'm just having a tough week. My dog died. Or you can say, yes, push the button and come in and get your treatments. So we're hoping that by applying some machine learning algorithms and getting more data on more patients to learn who are those patients who are just gradually worsening, and who are the ones that are just going to crash overnight, need to move very quickly. Maybe they get 1 week of high numbers, high symptom severity. We need to move very fast in getting them in. Others have a little more time. And I'm going to present some of the data from this in June at the Clinical TMS Society, so I won't scoop myself here. But I will summarize with some of my thoughts and just the big strokes of what we've learned from the literature on what to do after an acute course of TMS by saying, we know it's effective. We know it's effective for getting patients better that are not getting better with standard treatments. But we also know that depression, and particularly pharmacoresistant depression, is an illness that's going to come back. You're going to relapse. You might relapse slowly. You might relapse quickly. You might last 10 years. You might last 10 days after your last treatment. No one has the crystal ball. We don't know the best method for preventing relapse. And by method, I mean, is there a certain schedule? Is there a certain criteria we should use? Should we come in and blast them all in one day, or should we spread them out? We just don't know yet. I think personally, my hypothesis is that a personalized and data-driven approach would be ideal. But in order to do that, we need to learn about people. We need to get them monitoring themselves and see what their patterns are and be able to catch them in real time when the symptoms start to come back. Because sometimes I've had patients come back after many months and they say, oh, I should have come back. My depression came back, but I just didn't want to come and tell you about it. And I was hoping, I was in denial, But the data and something ecological momentary that's in your hand, in your smartphone, that's in your face, can say, okay, you meet criteria now, come on in. Eventually, when we get this all sorted out, then we're going to have to do a large prospective trial and show that it's superior to the regular standard of care, which is do nothing until patients are severely depressed again, and that it improves quality lives and is cost effective and feasible. But people out there, nevertheless, despite the lack of insurance coverage in this country and despite the lack of prospective data, people are trying all sorts of different maintenance therapies, strategies for their patients with TMS. My bottom line is to encourage people to do things that are evidence-based, that have been published, that have some safety data surrounding them, rather than to make up something yourself. And if you do make up something yourself, then you can't take money for your patient and say you're treating them. Then you have to say they're a subject in research and they should sign informed consent, and you should probably pay them to give you the data. So I think I will end there and take a minute to thank you for inviting me to speak to your community. I hope this has been helpful. I'm happy to answer any questions you have.
Great, thanks, Linda. That was wonderful. Thank you very much for sharing all that data with us and your viewpoints on those. So you told us a little bit about your aspirations for the future. Is there anything to do with the biological mechanisms mediating or underlying the TMS response? I mean, you talked about predictors of response and how to sort of personalize the durability of responses. Any sort of, I mean, obviously we're looking at neuroplastic effects of TMS. And so one of the questions that came to my mind is, well, if we can isolate the mediator of the TMS effect for this person, perhaps we can personalize the durability of response or the maintenance. Have you got any comment on that?
Yeah, well, I mean, presumably we're looking at neuroplastic effects. I want to just reiterate that the mechanisms that bring about the therapeutic effects of TMS are not known. And we assume they're neuronal, but there's all sorts of non-neuronal tissues in the brain. There's the whole glial vascular network. And so I do think that general brain health and plasticity probably allow people to hold on to their benefits longer, right? And so then I guess the ultimate question is, if we make that assumption, I'm happy to buy that for right now, what helps people have more plastic brains and healthier brains that will hold on to these plastic changes longer? And so when I think about how to answer that question, I think about all the things you can do to have just general good brain health, right? You can eat well, you can have your omega-3s, you can exercise, you can get sunshine and fresh air and lots of good sleep. And I tell my patients that all the time. I say, in the absence of data about anything else, I will tell you what I know is good for general brain health. And I think that might help people to hold on to the benefits. But beyond that, I think that there are opportunities for us to find neural markers. I like concurrent EEG, and people are using fMRI and fNIRS and a bunch of other methods and technologies to try to figure out, I'm hoping eventually, how to capitalize on signal that suggests durability of plasticity, right? And how to keep tweaking whatever it is that we're doing to incite plasticity to maintain it. I think we've got a ways to go to figure out what that signal is that we want to propagate and cement in to give a greater durability over a longer period of time. And presumably, once we understand those signals, we'll be able to detect them. There's a whole bunch of other things besides entering your symptom responses in an app that an app could be doing, right? It can be measuring a lot about your body, your movement, your voice, your pupillometry, your heart rate variability. There are many other physiological signals that we are starting to understand are important to convey the state of brain health. And that depression isn't just a brain disorder; it's a full body disorder. So, I'm very enthusiastic about those. Unfortunately, many of the patients that we treat now are beyond the age where they're inclined to have wearables and smartphones in their hands very often. But I'm hoping the next generation, babies who are playing with their smartphones in the cradle, will be ones that we're getting all these really great readouts on, and that we can use them intelligently.
And for clinicians who are new to this area, what do you consider the main advantages of neuromodulation techniques like TMS in comparison to other therapies, and why should they start to consider introducing it to their clinic?
Yeah, well, in this country at least, and I'm going to be radical and say I kind of agree with this. TMS is not a first line treatment. And I'll just say there may be some situations where it should be tried before psychotherapy or medication, but it's expensive, right? And so if you think about allocation of limited healthcare dollars that you may have for your country or community, if you could take something as cheap and easy as a generic antidepressant pill every day and get better, then that would be the way to go. There are side effects associated with many of our antidepressant and other psychotropic medications, and those portend long-term adverse health outcomes, weight gain, sexual dysfunction, and so forth. But in the absence of those, there might be other situations where TMS is a first-line treatment, and somebody who's pregnant or nursing and not wanting to expose their baby or their developing fetus to antidepressant or psychotropic medications that could impact that developing body and brain. And children, there may be other situations where you want to treat an illness like depression, but don't want to expose to medications. However, I'll have to pause on that one and say the very best available double-blind randomized control data we have in adolescents did not suggest that TMS is effective for depression. And that may be that the very few and smallish studies we have, aren't ideal with regard to capturing the right patients, and placebo effects are high. Nevertheless, there are situations where neuromodulation might make sense as a first-line treatment. But what's really spectacular about it, in my mind, is that when the more convenient treatments, like taking a pill every day or talking to a therapist, don't work, or when they did work and then they stopped working, prior to TMS, the standard of care had been really going to electroconvulsive therapy, right? And it's a highly effective treatment, ECT. I think it's used around the world, maybe some places more than other, and maybe in older people more than younger. But the side effects associated with it, unfortunately, for some people involve cognitive deficits. And so then they end up trading their depression for some problems with their memory. And there can be cumulative effects over time of doing a lot of ECT. So this is where I think there's a special place in our treatment toolbox for neuromodulation and TMS. And right now, TMS is expensive because we have these big devices and people have to come to a clinic and there's a lot of staff involved. But eventually, next generation of neuromodulatory devices include take-home devices, wearable devices, self-administration devices. I mean, we've got in the neuromodulation world, we've got an implanted vagus nerve stimulator, implanted deep brain stimulator, but there are a whole array of really exciting devices in development that stimulate externally, stimulate peripheral nerves, use low intensity of electricity and other sorts of energy sources like ultrasound and acoustic mechanotransduction. And so I think when medications fail, or when we learn that there's a particular biological substrate that we can target more specifically with neuromodulation, then it really makes sense to go. And I'm hoping not only in psychiatry, but of course, now there are large-scale randomized controlled trials showing that TMS has benefits for smoking cessation, obsessive compulsive disorder, and I'm hoping that there's an opportunity to bring a new therapeutic realm to all sorts of behavioral disorders and all across neuropsychiatric disorders.
Well, it's certainly a very exciting field to be a part of, and we appreciate all the work that you're doing to help elucidate all of these factors and increase the effectiveness of care for all of our patients. So thanks very much for that. Thank you for being with us today, and I look forward to perhaps in the future catching up on any future work that you do, and you can continue to bring us up to date with all the advancements in the field. So thank you very much, Linda.
My pleasure. Thank you.